Thank you very much. I'd like to thank the organizers for giving us the opportunity to talk about immune checkpoint-induced arthritis and the trial which will compare tocilizumab versus corticosteroids. I have a notable a grant from Fresenius, which is a maker of a biosimilar of tocilizumab, which is funding the trial I'm going to talk about. I'd like to put this into the context. In 2020, there was my boss, Xavier Mariette, had the idea of putting together people who knew each other, worked a bit together, but needed stronger bonds, and to improve the collaboration into clinical research, education around cancer and autoimmune disease. And he was the head of FHU Care with Professor Lambotte and Professor Marabel. And this was a great opportunity for me to develop a research agenda. And I was lucky, and I would like to thank all the participants that we were allowed to pursue this effort for the next 5 years and to be able to keep working together towards new treatments and specifically clinical trials. Inflammatory arthritis is a new disease when it comes, when it is due to immune checkpoint blockade. It's not like rheumatoid arthritis. It can have several clinical presentations and can induce arthritis in only one joint or several joints. It can specifically induce tenosynovitis, which is inflammation of the tendons. And contrarily to most IRAEs, it's rarely acute. Only 13 to 16% have an acute presentation and can be cured. Most people will have a chronic disease that will continue even if immune checkpoint is stopped. Another form of the disease is ICI polymyalgia rheumatica. This involves periarticular disease involving scapular and the pelvis. It has interesting feature because it can occur without CRP increase. It can sometimes be only a PET-CT finding without any symptoms. And contrarily to classical PMR, it is usually associated with arthritis. And it's been recently shown by a team of Bordeaux and McGill University that having arthritis when you have PMR leads to longer persistence of the disease. So why tocilizumab? Tocilizumab is a drug that has been licensed for RA, and as a rheumatologist, we've been using this for decades now. It's been used off-label for the treatment of immune-related adverse events, even other than arthritis. I'm going to show you a bit of data on that later. And as you saw, it's been used to treat CRS in CAR T cells, and it's been shown to be safe and doesn't impair the anti-tumor response in this context. Another interesting finding is that it's been shown that CRP, which is one of the feature downstream of IL-6, can cause a diminished response to immune checkpoint blockades, even at low levels. As you can see here, they divided the survival analysis at a median of CRP of 5.5, which is the threshold of the positivity. So even low levels of CRP can lead to less response. And so IL-6, which completely abrogates CRP levels, could be an interesting drug to improve the efficacy of immune checkpoint blockades. The other alternative is steroids, and it's been discussed widely yesterday, and this slide has been shown by Jean-Marie yesterday, but steroids are an interesting drug. They're probably the most fast-acting drug, and they cannot be replaced to treat IRAs, but they need to be tapered quickly. And as you saw here, the peak dose is probably the thing that is less favorable for anti-tumor response in this study compared for the high cumulative dose. Other data in the rheumatologic world have compared the efficacy of 3 drugs which are commonly used to treat ICI-IA, so inflammatory arthritis, which are methotrexate, anti-IL-6 receptor, and TNF-alpha inhibitors. And so, interestingly, the two biologics seem to have a faster time to control of arthritis, but they significantly, for anti-TNF, reduce time to cancer progression. So they have to be used with caution and weighted against the risk of cancer progression. Tocilizumab is in the middle. It hasn't reached significance in the impact on time to cancer progression in this study. These results are, however, to be taken with caution because, of course, in the most severe patients, there are higher doses of steroids, and they were not the same in the methotrexate group compared to the biologic groups. And these high steroid doses, as we have seen just before, might have an impact on anti-tumor response. So retrospective data have to be analyzed with caution in this context. Work from the MD Anderson, really nice mouse work, has shown a really interesting decoupling effect of IL-6 inhibition. Here you have a model, and it's a rare model where you have the autoimmune disease and the cancer at the same time. And so they've induced this. It's EAE, so it's a model of multiple sclerosis, not rheumatologic immune-related adverse event. But when you induce both diseases in patients and you use tocilizumab and immunotherapy, you induce a better control of the disease incidence of the EAE, and you have a better control of the tumor. So interestingly, tocilizumab may control the autoimmune diseases while not effective and maybe be beneficial in anti-tumor efficacy. Data in the recent data of tocilizumab regarding ICI rechallenge have been interesting. People have tried to reintroduce immune checkpoint blockade in patients with prior immune-related adverse events, and they tried to see how well it was able to control relapse of immune-related adverse event, and it seemed to be interesting, particularly for rheumatologic adverse events, where you have a much lower rate, as you can see here, of relapse, which is 2 out of 11, 18%, compared to 40% without TOCI prophylaxis. This is once again retrospective data, and there are major biases between groups. And what's interesting is you can see that for colitis, it doesn't seem to work at all, where you have even a higher proportion of relapse in patients with the with tocilizumab prophylaxis. Other groups have tried with larger, these are groups from the MD Anderson and others in the US, have shown that tocilizumab is effective in controlling mainly inflammatory arthritis with response rates up to 84%, and it doesn't seem to have, and it could be efficient in hepatitis, for instance, and maybe other things like polymyalgia rheumatica. In other indications, it seems to be less effective. And you can see that it is more effective when it's used in against a combination of ICI. When you have it's less effective when you have a history of of AID, autoimmune disease, and it's less effective also if you used a corticoid-sparing agent as first-line therapy, meaning that if it's used in a second line, it's less efficient than first line. Regarding in the same trial, the anti-cancer efficacy, they compared the overall response rate before and after the introduction of the tocilizumab to see how it impacted the anti-cancer, and they had a complete response rate of 8% improvement in the TOCI group compared to before and after. This is, of course, this has no control arm. And in the multivariate analysis, it seemed like age above 50 was associated with the best overall response rate. Finally, there are specific trials to combine tocilizumab to ipi/nivo in melanoma to improve the anti-tumor efficacy. Some results have already been published as abstracts, and this is the latest data the main pitfall of the first 30 patients was that the dose of tocilizumab was a bit low. It was once every 2 weeks, whereas the regimen used in RA, it's once every week. So they did another set of 10 patients with 162 milligrams weekly for 6 weeks, then every 2 weeks for 6 weeks, totaling 9 injections. They didn't see much of a reduced IRAE, so they still had 40% grade 3-4 IRAEs with a median of 4.9 weeks. As you can see, there were very little amount of rheumatologic IRAEs, which are not frequent, but you saw mainly liver and colitis. And what's interesting is that in this new regimen, the ORR seems to be quite improved when you do the TOCI every week compared to every 2 weeks. So it seems that the higher regimen of tocilizumab seems to improve the anti-cancer response, but doesn't have a major impact on the toxicity. And most interesting is that it seems that this overall anti-cancer response rate is better when you have high LDH, which are a subgroup of patients which are usually hard to tackle with any cancer therapy. So this is the context of the trial. This trial, I've presented this in 2022 in this meeting, and to this date, it hasn't started in France. It started in Sweden, so you need perseverance to have an academic trial, international academic trial, running in the field of IRE. This is the first, to our knowledge, a randomized trial in the field of immune-related adverse event. It's a phase 2 randomized open superiority multicentric. The main promoter is the Karolinska Institute in Sweden, and in France, I will be coordinating 4 centers, Bicêtre, Bordeaux, Brest, and Strasbourg. Other countries in Europe are Germany and the Netherlands. This will concern patients in the first line, and the design is the following. We will compare patients treated with 0.2 to 0.3 milligram per kilogram corticosteroids compared to tocilizumab with a quick decrease and stop at 2 weeks of corticosteroid in this group. In both groups, there will be tapering until discontinuation at week 12, and the primary endpoint will be at week 16. The inclusion criteria will be any cancer treated with ICI mono or combo therapy, at least 2 swollen joints, and a CDAI, which is the activity index, which doesn't include CRP because tocilizumab impacts and, as I said, reduce CRP to 0. So this cannot be used to assess the joint disease. So tender joints, swollen joints, and patient and physician activity scales will be used, which compose the CDAI. And patient with less than 7 days of steroids will be included, meaning that the patients need to be addressed to the rheumatologist in practice before the introduction of steroids. So there has to be a very good collaboration with between the oncologist and the rheumatologist and the internal medicine specialist who will be including these patients. The exclusion criteria is prior inflammatory rheumatic disease, concomitant life-threatening IRE requiring steroids, of course, steroids for oncologic manifestation that cannot be stopped, other immunosuppressive therapy, history of diverticulitis, which is one of the side effects of tocilizumab, and neutropenia, which is another side effect of tocilizumab. Primary endpoint, as I said, is the percentage of CDAI in remission below 10 at week 16 without treatment, of course. And the secondary endpoints will be the same amount of patients with 0 milligram of steroids at 16 weeks as well. Of course, PFS and OS reflecting the impact on cancer will be addressed, and the total number of missed ICI infusion will also be collected. We will also perform an ancillary analysis because the value of a randomized trial is a major to look at immunological mechanisms. So we will have 2 scientific questions: the prediction of chronicity, which patients at baseline, which features of the disease at baseline will predict chronicity of the disease, and then we will also assess prediction of response to tocilizumab and steroids, of course, and we'll use single-cell RNA-seq with available samples of PBMC, synovial fluid, and optional synovial biopsies. There have been work in the field, and this data from Gustave Roussy identified that LEAF, cytokine which is close to IL-6 because it shares the GP130 receptor of the IL-6, is also a cytokine which is impacting immune checkpoint efficacy. And as you saw, when it's high, it clearly shows a negative impact on the immune response. So notably, LEAF will not be inhibited by tocilizumab because tocilizumab impacts the other chain of the IL-6 receptor, which is IL-6R alpha. Another interesting thing is that refinement in the impact of the CRP analysis from the study I showed you, recent data show that the CRP curve is probably the dynamics under immune checkpoint blockade might have an impact. And the most favorable thing is that when you have a peak at the beginning of the immune checkpoint blockade, and then you go back to the normal, whether if you have no peak at all, or if you have a constant increase of CRP, you have a less favorable outcome of immune checkpoint blockade. So the full mechanism might explain why we don't see such a dramatic effect of tocilizumab in specific patients compared to others. And there's a trial in pancreatic cancer in patients with refractory to chemotherapy. They have been trialed on Ipi-Nivo, 15 gray of radiotherapy, and tocilizumab, and it clearly doesn't work. Median PFS is 1.6 months, OS is 5.6 months, and the waterfall plot is not really pretty. So it's not the therapy for everyone. It seems to be interesting in melanoma to improve anti-cancer efficacy, but we have to consider also the rest of the data. And this is a nice schematic made by Mathieu Rouleau-Dugage from Gustave Roussy, showing how IL-6 can be a central cytokine to prevent anti-tumor efficacy by increasing epithelial-mesenchymatous transition, increasing CD40 H17 polarization leading to immune-related adverse event, and impairing the CD8 cytotoxic potential, diminishing granzyme B, perforin, and interferon gamma. So this is the mechanism how IL-6 blockade could have a beneficial impact both on IRAs and on the anti-tumor response. I'd like, so the take-home message is that IL-6 is an interesting target for rheumatologic IRA. The hypothesis is that it might uncouple the response and the efficacy, the anti-tumor response and the efficacy on IRA. So it's probably an interesting drug. It seems to, the substantial improvement in the anti-tumor response remains to be demonstrated with melanoma. There is still no paper published, and we're still really interested in seeing this data finally published. And so the randomized trial might be a way to answer on the benefit of the immune-related adverse events part, and hopefully we might also have the anti-tumor efficacy, have a bit of data on that. Thank you for your attention. If I have a few minutes, François Xavier and the FHU Care have launched a bibliography, which is occurring every month. And the following one is next Wednesday. And so this is open to everyone. Everyone can present. And it's really interesting discussions between people from a variety of backgrounds who all speak the same language, which is immunology. So feel free to come and speak and present paper, your work, somebody else's work, your students, anyone. It's really a nice journal club to speak about immunology in autoimmune disease, any fields. And we will also have an interesting congress here in this room on the October 13th, which is the Odyssey of B-cell depletion in autoimmune disease, which will speak about CAR T-cell, bispecific antibodies, and other. We'll have international speakers. So this is also a rendezvous which might be interesting to the audience today. Thank you for your attention.
Okay, thank you for this very nice presentation. Any question?
Thank you for an excellent, very clear talk. I have a question about measuring IL-6 in clinic, whether or not it's useful, because there's a doctor in our center who has tendency to measure it and then say, okay, it's not elevated, so it's probably not an immune-related adverse event, or tocilizumab will probably not work. Is there a correlation? Do you have any data?
I don't have data on that. I think CRP is a good way to measure IL-6, and in my experience, the only issue is that when you use tocilizumab, you don't have CRP anymore, and in this situation, you cannot assess if the patient is failing the drug because you cannot have the CRP to guide you there. And in this instance, maybe in this situation, IL-6 measurement might be interesting.
Maybe a quick.
Thank you very much. We have many questions, but I'm going to stick to one comment and one question concerning the IL-6. We did it at Lausanne when I was there in immunology, and we couldn't do better than the CRP, so we just let it on site. Sometimes maybe we want to rely on a measure to think that it could be better, but I didn't see that in practically. And my question is, how do you treat right now your arthritis?
So.
And what's the place of methotrexate for you?
So we discuss a lot about methotrexate. I think it depends on the discussion with the patients and the time you have. Methotrexate could be interesting, but it takes time. It takes 2 to 3 months to work, and probably it's not as potent as tocilizumab and other biologics. But it looks like in the retrospective data, you take a smaller risk regarding the failure of anti-tumor response. So in the matter of the available data today, I think the discussion has to be exposed to the patients and saying, I'm going to give you a drug which will be more beneficial regarding the anti-cancer negative effect than steroids. That's the first thing I say. And then do you want it to work quickly? And maybe have I'm 85 years old. I have a couple of months to live, and I don't want to be in a wheelchair in my bed for the remaining months. Then I think this is a good situation to have tocilizumab as first line after steroids. If it's a young person who has a mild disease, then methotrexate may be the most beneficial to control the disease and take the lower risk on the anti-cancer therapy.
Thank you.
Yeah, thanks for the answer, but I'm a bit... I don't like methotrexate because once I saw a patient who had methotrexate and we stopped, and then after that she never had a relapse, and it's with a melanoma. And when you look at the data from the DAS paper or the BAS paper, it seems to be different between melanoma and other diseases. I don't know if you can comment on that.
I haven't looked specifically regarding that data. There is concern regarding methotrexate use in rheumatoid arthritis regarding, in one paper, an increased risk of melanoma, but it needs to be reproduced. So is there a specific effect in the melanoma? I think the data, maybe, but that's the only thing I can comment on.
Okay, thanks.
We have time for one question. Okay, thank you.
Thank you very much.